Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome back to another episode of Glasses Half Full. This one's for the pre-regs, okay? So pre-reg has multiple stages, and in stage 2 there's 2 parts. One of the parts is overarching competencies, case scenarios.
Can you say multiple if there's only 2?
But 2 is more than 1, and I feel the
But
definition
multiple implies more than 2, doesn't it?
numerous, few, several.
No, few, a couple of stages.
I mean, a couple of stages, I think too. It's still, there's
Is it?
several stages.
No, several means
What does
implies
it?
more than 2.
No, it doesn't.
Several implies
It's
7.
2.
Why are
No,
we
it
arguing
doesn't.
about
You're
this?
just making that up.
Several implies 7.
There's multiple, several, a few, numerous,
A couple.
a couple, parts to stage 2.
There's 2 parts. Well,
There's 2 parts. Okay,
there's 2 parts. There's 2.
there is. And prepare for both. We're going to help you prepare for one of them. Okay? There are 111, I feel we should know this, 111 case scenarios?
108.
108. Yeah, we knew that. 108 case scenarios, and we'll be going through a few of them. We do not want to bore you, and we do not have the willpower to go through all 108. We will have material for you for all 108, but you can't listen to us talk that long, trust me. I can't listen to me talk that long. So yeah, we'll go through a few of them, multiple, several,
A few.
more than a couple, from start to finish. Okay, so it's not all just going to be BV or the first 11, it's going to be throughout. So hopefully you should have a good idea. More importantly than what we say is how we work through them. Okay, this isn't for you to memorize. Please don't. Please trust me.
Don't.
You'll fail.
Do
We may say some things that are wrong. or
We
some
will.
things
We
that are right.
probably will say, regardless, act if whatever we're saying is.
And also, your assessor might not ask you the questions around the topics that we're talking about. He may or she may pick an entirely different aspect of that scenario and explore that area with you. So it's about having a holistic picture of that patient in front of you and being able to deal with any part of the eye examination or any part of the eye health.
And despite our best efforts to be as thorough as possible, we will not be able to cover every single part of what they could ask. And it's impossible to be that thorough and for you to still listen or for us to still speak. So yeah, focus on how we do the working out, listen into what we do, and then take that and...
Or don't take it.
Or don't take it. Absolutely. You don't have to.
Use your own clinical judgment. This is not
Not this
clinical
again.
advice.
So yeah, take it with a pinch of salt, but look at how we do it, not necessarily the words that we say. That's very important.
Yeah.
So, should we start?
Let's go.
We're best to start off from...
Let's start with scenario 1.
12. What?
What?
No,
Okay.
exactly. Start with 1 if you want to.
Let's start with 1. I think that might.
Mehdi, let's hear it. Run through it, and then we'll piece it apart as we go
Alright,
along.
Let me bring it up then. So, where's it downloading? Okay.
Very well prepared.
Right. So, this is case scenario 1. So
We
the
established
patient, the patient is a Caucasian male, aged 18.
Through piece of information, already very important. Certain demographics and ethnicities can be more at risk of developing certain conditions. For example, Afro-Caribbean are more at risk of developing glaucoma, so on and so forth. So, and then we are on to male. For example, females are more at risk of optic neuritis and other conditions. They also may indicate some specific drugs that may happen later on. So already you can take from that. Also, color blindness and things like that, much
More
more
in male than
common in
women.
male. Exactly. And 18.
18.
So, what do you think, Maddie, when you see 18?
When I see 18, I'm like, the problem will probably not be something like AMD. Do
Absolutely.
you know what I
Could
mean?
be.
I mean, it could be.
Is
but
it,
when
is
you
it going to...
no, well, it won't be AMD because it won't be age related.
Ah, right. It would just be.
There might be some form of macular degeneration, but it
Okay.
won't be age
So yeah,
related.
so they're not elderly.
You can so you can rule out some conditions, but obviously you need more information to judge on what you need and what you know. So, shall I carry on?
Let's hold on for a second. Looking at age, I'm thinking about two separate parts. One, which is exactly what Mehdi described. Some conditions are more likely with age. AMD, glaucoma, cataract, loads of them, most of them. Don't quote me. And the other one is, what are they likely to be doing in that stage of life? Okay, if they're 75, they're a lot more likely to be retired than if they're 25. If they're 10, what tasks will they be involved in? 18, yeah. Studying, that sort of stuff, maybe starting a new job, etc. Maybe
At 10?
no,
Jeez,
18.
living in the
18.
Victorian era, this guy.
Listen, get those kids working. They strive for the minds. So yeah, 18 might just be starting driving. They might be starting a new job, regardless. Okay, and if you could continue.
I can continue. Yeah. So occupation and hobbies. There are A-level students who
Called
also study medicine. And they're not driving, so they're a non-driver. They like cinema, socializing, and reading. Any comments on that part?
I mean,
Sure,
when you see cinema, socializing, and reading an 18-year-old, I think the takeaway that I see there is that there's not anything hyper specific that I need to worry about when it comes to dispensing.
To me, that tells me nothing.
Yeah.
Like if I see a 75-year-old who says I do an excessive amount of close work, fine detail, arts and crafts, then I'm thinking about reading glasses. I'm thinking about working distances. When an 18-year-old says they watch the cinema and they like to read, I'm thinking general purpose.
From this specific section, is there any point that you feel like could be something that you might want to consider going down?
Sorry, say that again?
From this specific occupation and hobbies section, is there any specific
Anything
interesting that you think might be relevant as you go through?
Well, having been through more than one of these scenarios, you start to learn that nothing's just there for no reason, except when something's there for no reason.
Yeah.
If they're saying that they are an A-level student and they read, then seeing that the next words are headaches, you start to gain a picture.
Yeah. So you're considering that maybe you might be thinking about the BV issue, but obviously you need to read.
Well, not even jumping to BV, but just strain IFD focused A-level student. Okay, A-level. That's one of the more demanding.
Yeah.
And medicine, again, just showing you demanding workload up top.
Right. So symptoms in history. They're getting frontal headaches, usually towards the late afternoon, early morning.
Early
evening. My bad.
Reading comprehension, very important.
And then they disappear after sleeping. Currently studying for exams, which are in 1 month's time. Vision's good at distance and near. Never worn spectacles. Had a twig in the eye when they were 6. Treated at hospital, doesn't know which eye it was. No long-term effects. Paternal grandmother has cataracts.
That's an example of some of the information that they put in there that's not particularly relevant. If their grandmother had cataracts, there's not a great deal I'm going to take away from that.
The second half of that paragraph is not really...
It's useless.
Yeah, maybe not the second half.
I mean, some of it is very... good vision, distance and near, never worn spectacles. These things give you a picture, but I don't think that there's too much you can draw conclusions on.
They give you an expectation on what you would be expecting to see with the test that you do. Do you know what I mean? So it's like you have a blurred image and they're just resolving it a little bit for you.
Twig in the eye, irrelevant.
Yeah.
I can't remember which. Yeah.
And
age
no
6 years
long-term
old.
effects as well.
No, unless it's long-term scarring, which you know which eye.
Yeah.
No, nothing that long 12 years ago is going to have an impact on the cornea. No long-term effects, so it tells us that. And yeah, as Shoaib said.
Is there any points from this specific area that you think could be developed on in terms of history, could be improved on, that you consider?
I mean, this history and symptoms is taking a part out of history and symptoms. It's not the full history and symptoms. So there would be surrounding information that I would ask, but not necessarily in this case scenario something that I would consider relevant. But yeah.
I think there's one point that I would probably want to ask about that I don't think is mentioned in history and symptoms.
Diplopia?
Yeah.
Yeah.
So it's not mentioned. Headaches are, but
if an 18-year-old is having strain headaches, then if they're having diplopia, then you could be thinking about convergence insufficiency.
Yeah.
Or something more.
Not always. Obviously, not everyone with convergence insufficiency has diplopia.
Of course.
But diplopia, I feel like is a relevant line of questioning. Yeah.
In fairness, I ask diplopia of every patient that walks
Yeah,
in the
yeah,
door, so
course.
it should be
Yeah.
questioned.
But that's
regardless.
something that I would say I'd pick up on it and be like, they should have probably asked that.
Essentially, because what your assessor's first going to ask you to do is to go through the scenario, present your findings, present your management, and tell them what other tests you want to do. These are not complete, full clinical records with
Yeah.
everything perfect about them. They're deliberately left with some missing pieces for you to identify what's not there. And as you do more of them, you'll start to gain an idea of what's normal and what's not normal. And just based on your own practice, from your own record keeping, you should be making a comparison of, wait a minute, I normally ask about diplopia. An 18-year-old with headaches, why have they not asked about diplopia? That's an important question.
The one good thing about this is that it gets you to understand how working in real life would be as well, because you're not going to blanket ask every single question for every single symptom.
Yeah.
You're going to direct your questioning to a specific set of symptoms that you're looking for, essentially based on
you
what they're
wouldn't
presenting
you wouldn't
with.
ask this patient, when you look at windowsills, do they appear straight or wobbly when
Exactly.
you compare each eye?
Exactly.
These aren't relevant
So
questions.
it's good to know the types of questions that would be relevant and whether they're included in the case that's presented to you. I think it was good to move on. Yeah.
Health is good. No medication. Mum has hypertension. That's fine. Present RX centrations and acuities. There is none because he's not wearing any glasses or spectacles. PD NCD is fine. Vision's good. With pinhole is exactly the same. And refraction is there, plus 050 with plus 025 and plus 050.
Any points that you think is
Nothing
relevant
really
here?
Unremarkable.
I think maybe refraction.
There could be something, but that in and of itself,
It's not enough
vacuum,
to
in a
But
vacuum,
the refraction, I mean, it's minimal.
Yeah, it's not, for example, a -3 prescription
No.
in and of itself is noteworthy.
Exactly. Yeah.
But this in and of itself, I wouldn't say it's noteworthy.
No.
It may become noteworthy later on.
Also, you may want to transpose that.
If you like.
Yeah, you don't need to.
So the VA comes after this, which is important to note the way that they write these scenarios. In the first paragraph above it, it says vision, and then below it says VA distance. The VA here is with RX in place, and the vision before is unaided. These are always given separately, so it's important to note what they are.
I kind of hope that you do know what they are, if you're on Stacey.
Yeah, the difference between vision and VA.
VA.
So presenting vision or presenting VA and refracted VA. Because they won't always make it clear here. It doesn't say refracted VA, it just says VA distance.
Yeah. All right, okay. So you've done VA distance, and then near is also N5. Accommodation, right.
Couldn't get N4?
Sorry?
Couldn't get N4?
Couldn't get N4. Damn. Send them
Not
hospital.
Not good enough.
Accommodation, right eye 12 diopters, left eye 12 diopters, binocularly 12 diopters.
What is the equation for the expected amplitude of accommodation?
The normal value would be the calculation for amplitude of accommodation, which would be 15 minus a quarter of their age.
So 18 a quarter of 18 is 4.5.
Yeah, so 15 minus 4.5, which is 11 and a half. Right?
Take the age, divided by 4.
No, 10 and a half. 10 and a half.
Good thing it's not math exam.
The age in years, divided by 4.
Yeah.
And take that away from 15.15, and that will give you what
10 and a half.
The minimum amplitude of accommodation should be. Beneath that, they would have
accommodation insufficiency.
Accommodation insufficiency.
Jinx.
Which they don't.
Which he doesn't have in this case, because 18 divided by 4 is...
18 what? 18 divided by 4? Why are you dividing?
4.5.
4.5, 15 minus 4.5 is...
Why are you teaching the maths? It's 10.5.
10.5. We had this discussion. We've come to this conclusion while you were there monologuing.
I'm just trying to do the maths.
You needed us to do it for you.
Exactly. That's what I said.
Yeah. As Shoaib said, the accommodation measured should be higher than the equation result.
Yeah.
The equation result's 10.5, this is 12.5, no accommodation insufficiency.
Right, okay, so binocular status without the prescription, so know whether it's with or without. This is a cover test. So distance 4 prism esophoria, near 12 prism esophoria, slow recovery. And then with prescription, I'll just finish it off. We've done a Maddox rod, 2 prism esophoria, They've done near Maddox wing, which I think is a typo, which is 10 esophoria with slow recovery.
Slow recovery. We do not like seeing that.
We don't.
Keep that in mind.
Also,
What's
any
missing?
comments about this particular binocular status
So-
examination?
Again, on the point of what is
What's
missing.
missing?
From, what's
So
missing,
much.
Yeah.
So much is missing. What is the recovery speed for the unaided distance
Yeah.
cover test? And also, just to note, by the way, if they're going to present to you a case where somebody's having headaches and they show you the binocular status with and without RX, there's something to draw a comparison between. So that's something to definitely pay attention to. Sorry, go on.
On a separate note, verbalize your thinking. For example, you'll probably assume that because they mentioned that the near was slow recovery, that the distance won't be slow recovery. Say that you want the recovery. Don't just assume because there's no information there that it's good recovery.
Lack of information is not information in this case.
Yeah.
Absence of information is not information of absence.
Okay. Yeah.
Distance Maddox rod, 2 prism esophoria.
Yeah.
Okay. So yeah, we need controls. We need Maddox rod before and after. We need cover test before.
Yeah,
and
I think
after.
one point that you would, well, I mean, one of them's objective binocular vision testing, the other one's subjective binocular vision testing. You'd want to do the same type of testing with or without RX, because then you'd get a more accurate result
Yes.
and more comparable result.
The Maddox, the subjective, because
The Maddox, yeah, rod and wing are subjective, and the cover test is objective. Personally, I think objective is the way to go.
There's a place for all of it.
There is a place for all of it.
Depending on the clinical situation.
Definitely.
Don't listen to Mehdi.
No, but
No, there is a place for all of it.
there is a place for all of it. But objective, obviously, in my opinion, okay, I feel like is the way to go when it comes to testing binocular vision.
So we have a fixation disparity with a near mallet unit in the right eye, 2 prism base out,
Yep.
or binocular plus or 50 eliminates the slip. So, I mean, from that we can.
That tells you a lot.
That's
That
the
tells you everything.
That's the answer to the question, basically. Patients coming in with headaches plus O50 in both eyes resolves that near slip.
Resolves an issue that's present.
The issue, which is that when you do the cover test, there's an esophoria with a slow recovery,
Yeah.
and according to the mallet unit, a plus or 50 in both eyes does the trick.
Plus of 50. Where have we seen that?
Wait, what?
Where have we seen plus of 50? Oh,
I wonder.
The
Their
refraction.
prescription.
I'm not
So-
doing it on that.
Are you not?
so yeah. I mean, it should all just be like a jigsaw piecing together. Motility full, no diplopia.
Good.
Good to know.
Good.
NPC is normal.
Yeah.
Sub 10 centimeters is a good number.
Yeah.
I mean, it's 8. It could be better. He's doing
So
medicine.
10 is your cutoff for normality, basically. So
Yeah.
anything lower than 10 is considered normal. So 8 centimeters is fine. So we know that's not a convergence insufficiency issue.
We know what the issue is, but anyway. Yeah.
Yeah. So it's not convergence. I can't say convergence insufficiency today. It's not that, and it's not. I know, and it's not accommodative insufficiency either. So what do you think it is?
I think it's a plus or 50.
I think he's slipping a little bit.
What's the name of it though? If it's esophoria, so the eye is turning in.
Convergence excess.
There you go. Because esophoria, it means what? The eye's turning in a lot when they're looking up close.
Yeah.
So it's excessively
So
converging.
what would you do to resolve this aside from prescribe the prescription or give prisms?
Well, I think giving prescription in this case is a very valid point.
What else could you do
When
when he's not in exam season?
you mean exercises?
What exercises can you think of?
Stereograms.
Stereograms.
I think so. Yeah, it's stereograms.
Yeah, no, absolutely.
You give stereograms.
Good.
Okay, let's continue because
And that's the
we're
cat one and the bucket one.
already jumping to answers.
Yep.
But let's continue. Okay. Pupil reactions. Yeah, they didn't mention anisocoria. They didn't mention RAPD.
Yeah.
Always nice to see.
Glad they checked that.
Oh, a sigh of relief every time.
It's upon examination, see attached, field see attached. Pressures are absolutely fine early in the morning. Pressures are, if anything, likely to be a little bit higher earlier in the morning. But some angles open, the non-contact tonometry, the
AO's angles open,
and then NCTs, the
non-contact tonometry,
Okay.
because we didn't feel like doing GAT in this.
On this
Would you
18
Would you know the gout, everyone? Shocking. So
Have you expected?
Scotland maybe to claim the fees, but
oh.
cut that out.
Okay.
Okay, fund this image.
Love you, Scotland.
Fund this image.
Fine.
Perfectly normal.
Yeah. I'm optic nerves
What
are
CD ratio?
CD.
4?
The I wish
4?
I no, a bit less than
A bit
that.
less than that. I'd say
It's
2.5.
3.
0.25 or 3.
3, yeah, maybe a little bit more in the right eye.
Oh, look at that blood
The
vessel.
right is a bit larger.
So that's 3 to 4.
Okay. I wouldn't.
I wouldn't go 4. I would go,
Okay.
I would go 3.
I'd go 3. Maybe 3.35.
Shallow
Okay.
cupping anyway.
3.35.
No, 3.
Oh,
3.5.
Okay.
It's well-
3.1415926.
The CD ratio is pi.
That's not a cup, that's a pie.
External
There's no
eye.
papilledema. There's no excessive hemorrhaging. There's no.
Forget excessive. There's
no
no
excessive.
hemorrhaging at all.
Yeah, a little bit of hemorrhaging. is
There's
excessive.
acceptable hemorrhaging.
Yeah, the blood is inside the vessels.
The blood is hemorrhaging
Always a good-
along
Always a
the
good start.
There's hemorrhaging in your blood vessels.
Yes, there's no retinal detachment that can be seen.
when they show you one eye, say the other eye similar, you just know it's fine. You just know it's fine.
Fields.
Don't rely on that. Field multiple stimulus, hence you're not seeing any. What's the word? What's the error things called?
False
False
positives.
positives.
There we go. False
False
positives, false negatives.
Yeah, so this isn't. It's not a clicky field test. It's a response. So
Subjective.
Subjective. So they essentially
Aren't they
present
all
you with
subjective?
multiple stimulus. So I think it ranges from 1 to 4, and basically you tell the practitioner how many spots you see whilst you're looking centrally. So they've done that kind of field test. So they've not missed any points in either eye. Threshold sensitivity 37, 36. Well, there's not missed points, so you know it's not anything to be of concern.
Yeah, no,
fine.
the fields are absolutely fine.
Yeah.
The color vision, however,
Ooh,
oh, buddy,
spicy one.
yeah. The first, so yeah, it tells you, you know, we're looking at deficiencies clearly, and then protonopia.
Protanopia, yeah.
Yeah, protanopia.
Yeah, so they're missing the long wavelength cones, missing the red ones.
Okay, good thing he wants to be a doctor and not a pilot or an electrician.
When it comes to protanopia, how would you discuss it with the patient?
I'm not bringing up the word protanopia. I'm
Yeah.
just saying
You have
That's a
trouble
good
with
one.
colours.
Yeah,
You're colorblind. Okay.
you're colorblind.
I avoid using the word blind.
Yeah.
Yeah, you have a color vision defect, and then they'll probably say, you know, what does that mean?
Yeah.
And you'll explain mainly.
To be honest, in this case, I think the word colorblindness is not as bad because it's not
I think in any situation to an 18-year-old.
Yeah, but if you're mentioning, I think you went on the right track saying you have a bit of a color deficiency.
So you struggle with colours
yeah.
sometimes.
But I think it's okay to mention that it's more commonly known as color blindness. Anyway,
Yeah, no, agreed. But it's another point to mention. The patient does have a protanopia, does have a color vision defect.
Yeah.
So yes.
So what would you mention to this patient regarding the color blindness?
Well, you'd mentioned that. Well, at age 18, there's different set of considerations. If a child came in, you'd mention to the parent about career options and letting school know so they can adapt learning resources to be conscious of the colours that they use. At 18, there's not as much consideration that needs to go into their education. Obviously, actually, would you tell your university that you've got a colour vision defect?
I'm not telling anyone.
The thing that
They're not going to change the
possibly.
lecture slides at med school for you.
The only thing I think I would probably say is there's a good chance that it probably won't affect your career as a doctor because you're applying for medicine. But
Super, I hope you get in.
I would probably say it's always worth checking for any color vision requirements if you're going to specialize in anything. I'd mention that. just for them to be aware
But
of
yeah,
it.
medicine isn't one of the known careers which
It's not, but I'm thinking more on the lines of like if they want to become like a radiographer, and obviously scans have multiple different types of coloring and things like that.
Is there a colour vision limitation on radiography?
I don't think there is.
Okay.
But I'm saying
I've not filled out a form for it yet.
I've not filled that form either. But my point is that if there is something that we are
general
unaware
good
of,
advice. You know,
it's
it's just
good
general
advice
good
to give
advice.
them.
Just be
just
aware.
to be aware of it, just to make sure that if there is anything
What's
that
the
you want
oldest
to go
patient
into.
you've had that didn't know they were colourblind?
40.
You met a 40-year-old who had no idea.
They came in because
Why were you
they thought
doing
they were colorblind and they wanted me to
Ishihara?
do an Ishihara.
Oh, okay. Fair enough.
And I was like, yeah, you're
I was going to say, if
colorblind.
you're routinely doing Ishihara at 40-year-olds.
No. They came in. They were like, I was talking to my girlfriend about X, Y, Z, and we think that I'm colorblind.
I had a 17-year-old doing his apprenticeship as an electrician.
I had one like that too as well,
Oh,
And
couldn't sign it
that's
off.
tough.
it was a tough conversation.
That is the when they actually come to you with the form.
Yeah, and you're
Yeah.
like, I have to fail you on this.
That's deep.
Yeah.
That's deep.
That's and the thing is, it wasn't. I don't know how or why or this specifics. It was a while ago, but it wasn't upon application. They were in the apprenticeship.
How did they get in?
That's something I don't know. This
I think they get in and they're like, you need to fill this out if you want to like.
or maybe it was delaying filling out or something. I don't know. But the point was that this wasn't when he was just considering what to apply to. This is after
He's on the course.
he wants to be an electrician.
He's
Yeah.
training.
Yes.
Then
He
you're
doesn't
like,
fancy plumbing.
I hope he's doing well.
It's just-
I hope with
that's how you
whichever
bring up that
career.
conversation. Is, what do you think about pipes?
They don't electrocute you.
Yeah,
less chance of death.
might drown, but unlikely.
Right. Regarding the rest of like looking at the scenario holistically, and we've gone through everything now. Is there anything that you feel like we may have missed, or maybe needs a bit more development in our answer?
So I feel, correct me if I'm wrong, there's three main points to bring up.
Yeah.
One is the just recently mentioned color vision defect.
Yeah.
One is the slight hyperopia, which is fixing the E4 issues, the slow
Yeah.
recovery and the slip.
Yeah.
And the other is the NPC exercises.
No, NPC doesn't need
stereograms.
Yeah, stereograms. Yeah.
So
For
those
the convergence excess, not
excess,
convergence
yes,
insufficiency.
Exactly.
So those I feel would be the three main points for the management going forward,
Yeah.
and nothing else seems to flag up.
One
The
thing.
small things like asking about diplopia in the history,
Yeah.
things like that. But really, the management is going to be spectacles.
I think it's
conversation.
valid to prescribe spectacles for the exam period and then bring them back in for exercises.
Yes,
I think that's a valid thing, because obviously, I mean, you're not prescribing you Prism because they don't need it necessarily, but obviously, I don't think you'd want to try and reduce the requirement of glasses if you can, and I think exercises is a very good way to help deal with that issue.
If this
And
doesn't
it's a bit
fix
more of a long-term solution.
if this doesn't fix the headaches, make sure they come back or go to the GP.
Yeah.
Go to GP. If this doesn't fix the headaches, because their eye health is okay,
Yeah.
and their refraction isn't the issue because we've given them the refractive correction and it's not helping anything. So then it's not the eyes that are causing, or it's unlikely that the eyes are causing the headache, so they need to be further investigated.
By the sounds of it, it's a frontal dull headache towards the evenings
Oh,
as
yeah,
a
oh, yeah.
student in exam
Yeah.
period with
it
an
seems pretty
autistic,
And goes away after sleeping.
with an ESO
Yeah.
poor recovery. It probably is.
It's a
but
pretty open shut case.
Yeah.
But in your advice,
Yeah.
mention that.
Of course, it's always good to cover the what ifs.
Yeah, because you have your main diagnoses, but you also need to acknowledge your differentials as well, just in case the tests the results that you get from your test aren't actually matching with the actual problem. Because sometimes you can get that in practice, which is why it's important to cover all bases. But yeah, I think generally it's an open shut case, and I think we've basically done everything. So why does the O50 eliminate the
Because of the near
convergence
triad.
success? How?
Because the convergence is linked to the accommodation,
Yeah.
which is linked to the prescription. So as they're accommodating through the prescription, they're converging. There's too much of it.
Yeah.
So what we need to do is we need to give the prescription, relax the
Accommodation.
accommodation, which therefore relaxes the convergence,
Exactly.
and the ESO resolves into no movement detected on cover test, which is a
Yeah.
test that I would like to see done with prescription.
Hopefully. Great. I
We're
think
gonna
that's
smash
everything.
this. Okay.
It's all the near triad. Anything BV related is always it's just near triad.
Unless it's a nerve palsy.
Flashing lights floater is just near triad.
everything
Yeah.
everything to do with
Just like that.
BV is near triad.
IFP the 70 just near
Basal cell
triad.
carcinoma, near triad.
Near triad.
Not that stuff, obviously.
Okay. Yeah. So that's case scenario 1. Again, to reiterate,
Not clinical advice.
we're not giving you the answers. We're giving you how we got to the answers. Okay, that's the important stuff. It's not important that, oh, if this 18-year-old walks into your door and all the results are exactly the same as this, you know what to do. No, what's important is a patient walks into your clinic room and you have a process to work out what the issues are.
Yeah.
Thanks. See you in the next one.